A very good evening to all the audiences. A very warm welcome for this wonderful webinar. And I would like to welcome all our moderator, panelists, and speaker for this wonderful webinar which we have planned. Hetero has been working on various academic platforms, and we have been learning from last 2 years how to conduct webinars post-pandemic when we are devoid of physical meets. And beyond that, in fact, if we talk about Hetero, a company which is very young, started in 1993, and which was, I would say, the first company to get award within 3 years on an R&D award, the best awards in R&D efforts. We bagged in 1996. As a company, if you see, we have been fighting various pandemics right from the days of HIV. And in the early days or years of this company as well, we were capable of manufacturing high-end molecules like zidovudine, lamivudine, and all those antiretrovirals at the old times. And currently, we have also launched bictegravir. But when we talk about HIV, we cannot forget name of Dr. Saple sir, who had played a very pivotal role in spreading and disseminating knowledge about HIV/AIDS. We have other stalwarts also over here who have handled HIV very effectively. We have Dr. Sunil Patwardhan sir, Dr. Ganesh Dhavalshan sir, who are again one of the good names in managing HIV pandemic. When we talk about pandemic, bird flu, HIV, after HIV, then bird flu, we have seen HBV, we have seen HCV. All these high-end antivirals were launched by Hetero as soon as possible to fight this pandemic. Recently, we have experienced COVID-19. We were the first company to bring in remdesivir. We also developed favipiravir in a very short span of time. And beyond that, we were the first company to launch molnupiravir. In fact, to do clinical trials and launch molnupiravir. We also are the first company to launch tocilizumab, which is the Indian biosimilar, which was approved for COVID for that matter. And the studies are going for RA as well. But why I'm talking this? This is just to talk about Hetero strength and a very young company which started in 1993 with basic platform of R&D and developing molecules which can be affordable for the Indian patients. In the same lines, if you'll see various segments, we have worked all throughout the therapeutic segments. We have more than 300 molecules. And recently, we have also entered in the dermatology portfolio with high-end molecules. We have adalimumab, we have rituximab, which are used also in various rare indications like hidradenitis suppurativa, pemphigus vulgaris, and more. The recent molecules, the JAK-inhibs, which are basically the future, and the current many molecules are there in the global market. Some of them were launched in the Indian market too, but at very high cost. One of them, which I'm talking about, is Tofacitinib, where it has been experienced in dermatology quite well, and the outcomes are extremely good. At the same time, in autoimmune skin conditions also, there are many indications where it can be used very effectively, but there are many questions to be answered. And to do that, we are doing a lot of webinars so that the knowledge about use of Tofacitinib, the doctors of dermatologists who have used Tofacitinib can share their experiences and for the benefits of the patients and others. So on that grounds, we have carved out this one more webinar with our esteemed panelists on board. And to take us through this proceedings, we have our esteemed moderator, Dr. D.G. Saple sir, over here. Vijay. Who am I to basically introduce Dr. Saple sir? He's beyond that, in fact. But as a protocol, let me introduce Dr. Saple sir. Professor Dr. D.G. Saple sir is a fellow of Johns Hopkins University, Bloomberg, USA. He is involved. He was ex-professor in Grand Medical College, Sir J.J. Group Hospitals, Mumbai. He is involved in clinical management and research and training program on HIV/AIDS for last more than 30 years. And we have delivered more than 1,000 lectures in India and abroad. Ex-president IADVL, and has been awarded lifetime achievement in 2017 and 2018 by IMA and IADVL respectively, as well as awarded best practitioner by National International Conference of Dermatologists in 2019. In 2020, he was felicitated by IADVL Fellowship Program Dermacon Pune, first dermatologist to start fluconazole daily therapy. He is special interest in psoriasis, atopic dermatitis, and urticaria. Over to you, Dr. Saple sir. Sir, you're mute.
Are you on mute, sir?
Sir, requesting to please unmute.
No, what about your projecting those slides, no? Okay, okay. Yeah, can you project the next slide? Yeah, next slide. Okay. Yeah, first, thank you, Vijay and Hetero Healthcare for allowing me to share and conduct this program as a moderator. Thank you all panelists and speakers. In today's program, when you talk about tofacitinib or the JAK inhibitors, which is a very important topic in today, I remember exactly 7 years before I was attending one AAD meeting in New York. They were talking of JAK inhibitors. I was just listening to it, and one of the speakers was talking on vitiligo. I'm talking about 7 years back. Then I was after when this drug will come, because this drug is very important drug. You must have, you panelists must have used it, or other audience, they must have used it. But I found this is called fascinating drug. In fact, this drug is going to change the therapeutics of dermatology. So today we have a speaker, Dr. Balkrishna Nikam from Karad Medical College. Is also known not as a dermatology, but as a dermatopathologist. And he has got more interest in psychodermatology also. He has been awarded Dr. Siddhappa Medal and Dr. A.C. Parikh Award, and he has got more than 35 publications. So Dr. Nikam is going to give us a talk on tofacitinib, and we have 4 panelists. So I would like to introduce right now. So can I have next slide? Yeah, Dr. Sunil Patwardhan. Dr. Sunil Patwardhan, who is practicing as a dermatologist at Satara, I think is well known. I know him because we are associated with the HIV. We are working together in HIV for the last 25 years. So we are associated and we keep on exchanging. He passed from Pune, and his chief interest is clinical dermatology and dermatosurgery. And of course, HIV, he has not written, but I know HIV. Now, she is from Satara. Now the next panelist is Dr. Ganesh Dhalshank. He is from Kolhapur. He is a professor of Department of Skin and VD, Kolhapur Medical College. He had a 15 publication. He had a poster presented at the national and international. In fact, he poster presentation in EDV and Madrid and Spain. And he is very much active in the IDVL at the state level and the international and the national level also. So we'll go for the next panelist. Yeah, next slide, please. Next panelist is Dr. Renuka Astekar, who is presently professor and HUD Department of DBL Bharatiya Vidyapeeth, that is a Sangli Medical College. She is a postgraduate from Grand Medical College. In fact, she has done the post-graduation under me in the Grand Medical College. She had a first prize in the poster presentation. She had a special interest in clinical dermatology, dermatosurgery, and she had publication at the national and various national journal. So we'll have Renuka Astekar also. So we'll go for the next panelist. Next one is Dr. Aditya Mahajan, who is a fellowship of European Academy of Dermatology, fellowship of DASIL, award for participating in the various national and international. He had a lot of academic interest in trichoscopy, dermatoscopy, diagnostic, and clinical. You mention anything, he is very much interested in dermatology. And one of the things I would like to say that Aditya Mahajan's father, who is also dermatology, and he was my colleague when I was in JJ. Yeah, next one. So now I'll request Dr. Balkrishna Nikam to go ahead with his talk on tofacitinib. Yeah.
Thank you, Dr. Sape sir, for this wonderful introduction of ours. And at the outset, I'm very much thankful to you for giving all of us the opportunity to discuss about this wonderful molecule of tofacitinib. I'll share my screen. Is my screen visible?
Yeah.
Yes, sir.
Only have to go for a show. Yeah.
Okay.
Yes, perfect.
So I have 20 minutes for presenting this Topacitinib in dermatology. So we'll start with introduction. With emergence of new molecular targeted therapies, there is evolution in therapeutic dermatology. One such molecular target is JAK-STAT. The long form of it is Janus kinase, signal transducer and activation of transcription pathways. Variety of inflammatory dermatosis rely on these JAK-STAT pathways. Therefore, utilizing JAK inhibitor proved to be valuable addition in drug armamentarium for management of inflammatory and autoimmune diseases. So JAK-STAT pathway are utilized by many cytokines, including interleukins, interferons, and other molecules to transmit their signals from cell membrane to nucleus. There are 4 JAK family members and 7 STAT family members. Many dermatologically relevant cytokines rely on or they work through JAK-STAT pathway. These are some of the important cytokines, out of which interferon alpha, beta, gamma, and interleukin 2 related all interleukins. Interleukin 2, 4, 7, 9, 15, 21 are important. Also important are interleukin 5, 6, 12, 13, and 23. What is more important is which cytokines are not working through JAK-STAT pathway. These are TNF alpha, IL-1, interleukin 1, and interleukin 17. This you can remember. So how actually JAK-STAT pathway works? Here comes the cytokine which attaches to this receptor outside the cell membrane. Once it attaches to this receptor, the JAK are already associated with the cytoplasmic tail of that receptor. So they form the dimerization. Once there is a juxtaposition of this JAK pathway, JAK molecules, there will be a phosphorylation of the autophosphorylation of the JAK as well as autophosphorylation of the cytoplasmic tails. Okay. Now, because of this autophosphorylation of the cytoplasmic tails, the cytoplasmic STAT, they will also get attached to these phosphorylated tails, and because of this, the JAK phosphorylates the STAT also. Once the STAT get phosphorylated, they forms the homodimers or heterodimers. So these dimers went inside and they go inside the nucleus and they work as a gene transcription factor. This is all negatively regulated by SOCS, PTP, and PIS. That is not important in today's talk, but this is important. Once the cytokine comes here, the receptor JAK get autophosphorylated, this phosphorylated STAT, and the homodimer will go inside and forms the transcription of the cytokines. So loss of function of mutation in JAK3 is associated with the severe combined immunodeficiency syndrome, while JAK3 is overexpressed in cutaneous T-cell lymphoma. Also, loss of function of mutation in STAT3 can lead to immunodeficiency syndrome like Job syndrome. So what is the classification of JAK inhibitors? How the first generation JAK inhibitors includes Tofacitinib, Ruxolitinib, and Baricitinib. The second generation are more specific one, out of which important are Upadacitinib. So Tofacitinib is already FDA approved JAK inhibitor in the treatment of rheumatoid arthritis and ulcerative colitis. Ruxolitinib is FDA approved for myelodysplastic disorders, polycythemia vera. Baricitinib is currently much evaluated for psoriasis as well as atopic dermatitis and showing good results in atopic dermatitis. So there are 4 JAK families. Okay, so individual JAK selectively associated with different receptors. So these different receptors can utilize different JAK families. So each member is used by multiple different receptors. Thus, the ruxolitinib inhibits JAK1 and JAK2. So it's a strong opposer of JAK1 and JAK2. While Tofacitinib is actually a pan-JAK inhibitor, but it is chiefly inhibits the JAK3. But in higher dosages, it can inhibit JAK2 also. While Baricitinib is JAK1 and JAK3 inhibitor, and Upadacitinib is JAK1 specific. So we are talking about Tofacitinib, which is an immunomodulator of Janus kinase inhibitor. It is also called as a JAK inhibitor because it's a pan-JAK inhibitor. It blocks tyrosine kinase of the Janus family. The efficacy of JAK inhibitors in inflammatory disorder, particularly rheumatoid arthritis and ulcerative colitis, is known, and the potential of their positive effects in inflammatory dermatosis also. So what is the advantage of JAK over the biologicals? One thing is that it has easy oral route. Second, it never forms the neutralizing antibodies. And third important is there is a inhibition of signaling from multiple cytokines, not just one. So we'll talk about the mechanism of action, as all of us have already understood how the cytokines stimulate the JAK and through the JAK-STAT pathway, how they signals the gene transcription, and then how the JAK inhibitor will antagonize the effect of cytokines that we'll see in this figure. So before JAK inhibition, these are the cytokines, they attach to the receptor. Then there is a activated JAK will phosphorylate the activated STAT, and the STAT will go inside and gene transcription will happen, and that will produce lot many cytokines, right? Now, once there is a JAK inhibition, even after attachment of the cytokine receptor to the receptor, there will be a JAK inactivation. So there will be no phosphorylation of the STAT. So no activation of the STAT, there will be no gene transcription, and there will be a down regulation of the production of cytokines. This is how the JAK inhibitors work. So key pharmacological concepts of oral tofacitinib. First important thing is the bioavailability is 34%. The plasma protein binding is almost 40%. Half-life is 3 hours. It is cheaply metabolized 70% in the liver and 30% is excreted through the kidney. So all of us know the indications in dermatology are psoriasis, psoriatic arthritis, alopecia areata, atopic dermatitis, and vitiligo, and also used in other disorders, which we'll see in few slides. So coming to alopecia areata, now these are some of the good reports which are collected here. So this is a report in 2016 where is tofacitinib have been used in 5 mg twice daily for 3 months in alopecia subtotalis, totalis, and universalis. 64% of the patient responded to the treatment. 32% of the patient showed greater than 50% improvement in 3 months. The patients which have not responded are alopecia totalis or universalis. They responded less in 3 months. Shorter duration of the disease and histological finding of peribulbar inflammation showed good response. So how this works? The JAK-STAT dependent cytokines, interferon gamma and interleukin 15, they activate the autoreactive T cells in alopecia areata. JAK exactly inhibits this interferon gamma and interleukin 15 production. Another study is on 90 patients. This study is for 4 to 18 months in patient of 18 years and above. The scalp involvement should be more than 40% of the total area. In this case, 77% result was there. Almost 65 of the 90 patients were potential responders to the therapy. So 58% of these patients showed greater than 50% change. Patients with alopecia areata experience a higher percentage of change in SALT score than alopecia totalis and alopecia universalis. So 59% of alopecia totalis and universalis versus 81% of the alopecia subtotalis showed good improvement. This is one example they have given where there is a alopecia totalis is showing good improvement, almost the SALT score from 100 to 0. Here they have also given the algorithm. What they have stated, the alopecia totalis and alopecia universalis have greater than 10 years of duration. They are unlikely to respond. While the potential responders are alopecia totalis, universalis, or subtotalis having less than 10 years of involvement. They initially started with the standard regimen, that is 5 mg BD. Those who are showing hair growth, they continued after 3 months. But in 3 months, those who are not showing any response to the standard monotherapy, they either escalated the dose to 15 mg to 20 mg in a day, and also added the adjuvant therapy like prednisolone pulse therapy. So here another case which is published in 2014, where the patient is not having only not only having alopecia universalis, but patient was also suffering from plaque type of psoriasis. Patient received oral tofacitinib in 15 mg per day for 8 months and showed complete regrowth of eyebrow as well as the scalp hair. You can see this is in 2 months, this is in 5 months, and this is almost in 8 months. So coming to psoriasis, many studies have already been published on psoriasis. Mostly the studies are of 12 to 16 weeks. out of which these are the some of the important studies where the first study has used tofacitinib almost 10 milligram twice daily, showed very good improvement in 3 months. Another study showed used two dosing, 5 milligram twice daily and 10 milligram twice daily for 16 weeks. Naturally, the 10 milligram twice daily showed a good improvement. Another important finding of this study is prior treatment to biological agents were associated with lower response rate. And this study was for the itching severity score, where the 2 mg, 5 mg, and 15 mg twice daily, all these doses showed very good improvement in the itch severity score, pain and discomfort assessment. So how it acts, basically interleukin 12 and interleukin 23 are JAK-STAT dependent cytokines which are majorly serve as an inflammatory mediation psoriasis, which are suppressed due to tofacitinib. Interleukin 17 is not working through JAK-STAT pathway, but still interleukin 23 stimulates the production of the interleukin 17. So JAK-STAT pathway downregulates interleukin 23 and also the dependent interleukin 17, although it's not direct suppression. Coming to vitiligo, in vitiligo, this study is in case of one patient, 50-year-old female. The patient had received tofacitinib 5 milligram alternately initially, and thereafter 5 milligram daily for almost 8 months. And these are the clinical responses. Patient was not responding initially only on narrowband UV therapy. She continued narrowband UV and along with tofacitinib showed very good improvement. Here you can, the author has already published this case in 2015. Another retrospective case series of 10 patients received 5 to 10 milligram of tofacitinib twice daily for almost 3 to 15 months of duration of generalized vitiligo and acral vitiligo. So here you can see the reduction in the body surface area of the vitiligo in 5 out of 10 patients, and major reduction was seen in sun-exposed forearm, dorsal hand, dorsal of the hand, and the lesser amount of reduction in the body surface area of the vitiligo was seen in the hidden areas or sun protected lesion of the areas. How tofacitinib works? It has been demonstrated that depigmentation in vitiligo is mediated by interferon gamma induced expression of CXC motif chemokine 10. So interferon gamma signal transduction occurs through JAK1 and 2. Blockade of JAK with tofacitinib inhibit interferon gamma signaling, thereby down-regulating CXC motif chemokine 10 and thus leading to return in pigmentation. Coming to atopic dermatitis, this case series of 6 patients of age 18 to 55 years, tofacitinib was given 5 milligram daily as well as twice daily for 8 to 29 weeks. In the moderate to severe atopic dermatitis, there was a reduction in SCORAD 66%, reduction in the pruritus and sleep in 69.9%. So the advantage of tofacitinib is a reduction of quick reduction in itching also. So there is a typical clinical response. There is a decreased redness. You can even see the decreased erythema, excoriation and lichenification. So typically interleukin 4, 5 and interleukin 13 are inhibited or downregulated by inhibition of the JAK-STAT pathway in atopic dermatitis. Dupilumab works in a similar fashion. Dupilumab is inhibitor of interleukin 4 and 13. So this is an now JAK1 inhibitor, which is Upadacitinib, which has been studied head to head with the dupilumab and found to be more effective than dupilumab. Here you can see the 71% patient showed good result in Upadacitinib group versus in dupilumab it is 61% group. So it's good hope for the atopic dermatitis of JAK inhibitors. Coming to dermatomyositis, there are anecdotal reports. In one case, 3 patients with refractory dermatomyositis have been treated with 5 to 10 milligram per day, and the mean treatment duration was almost 10 months. And at the end of the 4 weeks of the treatment, clinical improvement was noticeable with good muscle strength. In another 2 patients, improvement from moderate to severe mild disease was observed. In both these patients, tofacitinib was employed as a monotherapy after failure of previous conventional therapies. It has been also used in actinic dermatitis, and within 2 months there is a complete clearance. So it is one of the good agent to be used in lichenoid photodermatitis or actinic dermatitis. also has been useful in 2 cases of cutaneous sarcoidosis and 1 case of granuloma annulare. In pyoderma gangrionism, it has been used along with biologicals like vedolizumab and infliximab and showed near complete clearance. Tofacitinib also has been used in dermatitis herpetiformis in a case of patient who was allergic to dapsone. There they have treated case with 5 mg twice daily tofacitinib. And there has been a recent study showed there is a role of JAK-STAT dependent pathway in the pathogenesis of dermatitis herpetiformis. Very interesting article. Similarly, tofacitinib has been used in lichen planopilaris recently in 10 patients, out of which 5 patients showed good improvement, particularly in the pruritus, pain, burning, as well as there was improvement in the erythema, scaling, and hair density was also noticed in 8 out of the 10 patients. Some of these patients may require an additional therapy like intralesional steroids and hydroxychloroquine. This is another very good report of baricitinib, which has been very much useful in 2 cases of treatment-resistant livedoid vasculopathy. Baricitinib is already getting popularity in treatment of atopic dermatitis. So thus, to summarize, tofacitinib holds a significant potential to broaden the treatment options for many chronic inflammatory dermatosis. It induces rapid improvement and has reported much lesser clinical toxicity. Tofacitinib has been found to be comparable with etanercepts, particularly 10 mg twice daily, not 5 mg twice daily, and as a second-line agent for psoriasis. Oral route of administration has better economic profile over biological drugs. Compared with other immunosuppressive drugs, JAK inhibitors have shown superior results. Tofacitinib appears to be possible candidate for treating many dermatologic conditions refractory to other treatments. Quickly through the adverse effects, it can cause urinary tract infections, different infections, nasopharyngitis, upper respiratory tract infection, as well as reactivation of the tuberculosis, varicella zoster. It impaired the responses of live vaccination, thrombocytopenia, anemia, lymphocytopenia can also occur. Common gastric side effects are diarrhea, fatigue, dizziness, headache. Uncommon is gastric perforation, and supposedly the theoretical risk of increased malignancy. Cytopenia and lymphocytopenia or thrombocytopenia is not very common with the tofacitinib because tofacitinib is not very strong inhibitor of JAK2, and the JAK2 is more utilized by erythropoietin, thrombopoietin, and granulocyte colony stimulating factor. JAK2 is more inhibited by ruxolitinib, so ruxolitinib has more likely to have a side effect of cytopenia. Although tofacitinib with the higher dosages can inhibit JAK2 and can cause thrombocytopenia or pancytopenia. Topacitinib and malignancy, a lot of talk about this. There is a theoretical increased risk of malignancy. Only in tofacitinib have been used in renal transplantation along with the other immunosuppressive agent have showed increased risk of lymphoproliferative malignancy. However, all other studies of ruxolitinib and tofacitinib in ulcerative colitis, rheumatoid arthritis, psoriasis failed to show increased risk of malignancy. There is an impaired response of vaccination has been reported with tofacitinib and is theoretically risk of ruxolitinib too. There have been reports of gastrointestinal perforation with tofacitinib therapy. Patient with increased risk of GI perforation should use caution. A new onset of abdominal symptom indicative of GI perforation should be promptly evaluated for early identification of treatment. These are some of the monitoring guidelines. Before starting tofacitinib, one should do complete blood count, renal function test, liver function test, fasting lipid profile, triple H marker, as well as testing for tuberculosis like IGRA or MONTU test. After 1 month, one has to repeat the complete blood count, renal and liver function test, and fasting lipid profile, and this has to be repeated every 3 months. Thank you very much.
Thank you, Dr. Nikam, for covering, I think, is a comprehensive or whatever it is needed for our practice. Now I'll start sharing my slide and then we'll start with the panel discussion. Yeah, so tofacitinib in dermatology, Dr. Nikam has covered most of the things, and then we'll start his actions, what are the type and what are the indications. So we'll start first with Dr. Patwardhan, Doctor, what are the indication you would like to use tofacitinib in dermatology?
Whatever they have mentioned, I mean,
Yeah.
like alopecia areata, vitiligo, psoriasis. I mean, I have tried only in these three conditions, but as Dr. Nikam has mentioned, there are many other indications where we can try it. Where we
But then can you increase your volume?
Yes. Now, am I audible now?
Yeah, it's perfect.
Yeah. So I would like to try. I have tried it in alopecia areata, psoriasis, and vitiligo. Atopic in adults we don't see so commonly. So maybe I'm not getting that many cases in adults. So I've not tried it, but I would like to try if I get a right patient. Then there are other indications, as Dr. Nikam has mentioned, where we can try it if the other therapies fail.
Okay. You mean there are other indication also, correct? No?
Yes.
Yeah. Okay, like dermatomyositis, what Dr. Nikam has covered, erythema multiforme, hyperinsulinemic syndrome, and cutaneous graft. So there are many indications we can use it, and there are some small indication also. So there are what we call is the offline indication. There are many. So we'll start with the patient. I think this question will ask Dr. Renuka. Dr. Renuka is a patient is 55-year-old male, chronic plaque psoriasis. We have started the topical treatment. Patient has got hypertension, but with the topical treatment, there was no improvement. So we started this patient with a cyclosporine. When we started with a cyclosporine, there was a good improvement. But after some times, the patient's creatinine started going up and the blood pressure also started going up. So Renuka, how you are going to manage this patient?
Sir, I would like to know whether this patient has received methotrexate at any time in the past. If not, then give the trial of methotrexate. And now, after listening Nikam's talk, also think of starting patient on tofacitinib after doing investigations, whatever has been mentioned in the talk, with 5 mg BD, because one of my 2-3 patients of diabetes and hypertension, they did not respond to the conventional line of treatment of psoriasis. I started them on tofacitinib, and really I had within a month, 4 to 8 weeks, I got a very good response. So I think tofacitinib will be a good option for this.
Thank you, Renuka, for sharing your experience. But see what we did. As you said, we started methotrexate on this patient, but after that, patient developed what we call is a hemoglobin drop, leukocytosis. So we could not continue methotrexate because of hematological side effects. So what we should do, what is the medication? So we started this patient, as you already mentioned, tofacitinib 5 milligram BD, and within 4 weeks, you find everything. So this is the patient I have treated about 1 year back. This is the very first patient of mine. So I think all of us, we are getting good result who are using this. So one of the option is tofacitinib. Now we'll go for the next patient, because I'm conducting, they said, can we use tofacitinib as a rescue therapy? For instance, somebody comes like severe psoriasis. So I'm asking Dr. Mahajan, can you use as a rescue therapy, tofacitinib as a rescue therapy in psoriasis?
In my opinion, only cyclosporine is the best choice for the user as a rescue.
Yes, I agree with you.
Tofacitinib at least takes around a month and a half to 2 months to act. So I don't think it can be used as an acute this thing. But we can use acitretin, or we can use cyclosporine as with much better results for rescue therapy.
Yeah. Thank you, because even I have got a good experience with the cyclosporine, and that's why we said let us try tofacitinib as a rescue therapy. So see, this is the patient with a severe erythema, severe lesion, but see, after 2 weeks, almost it has settled down almost more than 50%. These are the lesions on the elbow or the extensor aspect. These are the, so Then I tried, and then even Tofacitinib also is a very good drug, and we can use as a rescue therapy. We'll go for the next patient. I think this question I'll ask Dr. Dhaval Shang.
Okay,
This is
sir.
a patient of, you know that this is a pustular psoriasis. She had a severe pustular psoriasis and she has a fever, she had a tachycardia. We are admitted in the hospital, started with systemic steroid, but she has a diabetes and hypertension both.
Okay.
And then we reduced to 40 milligrams, the patient was discharged. So how you are going to manage this patient?
I think I will go for her lipid profile first.
Yeah.
And try to put her on acetatin.
Yeah, but with the pustular psoriasis, because acetatin usually for the action, it takes longer time, more than 3 to 4 weeks.
Okay.
Yeah, longer time. Yeah. But that is one of the option. Yeah. Anything else? I think Renuka, you would like to add in this pustular psoriasis?
Yes, sir. We can start cyclosporin after the drug of choice.
Yeah, but she is hypertensive and diabetic both.
Diabetic.
Then methotrexate.
Or other panel, or Dr. Nikam.
Sir, I'll use a combination therapy, acetatin plus methotrexate.
And methotrexate. Okay, yeah, because there's, yeah. So what we did, this patient, we continue tapering the prednisolone, and while tapering, we started 10 milligram BID of tofacitinib. When we started with the 10 milligram, and after 2 weeks, see all lesions are under control. And if you see after 6 months, now we have seen she had come about 3 weeks back. She's only 5 milligram of tofacitinib, because to control or treat pustular psoriasis is a Herculean task, and we do not have good, but then I found this is one of the good options. So I have treated 2 patients. This is one of my patients. She is very happy because she has got hypertension, she has got diabetes, and she is about 65 years old with a comorbidity. And at the end of 6 months, we are following. So we'll go for this. So Dr. Balkrishna has shown the trials about the psoriasis. When you're using the higher doses, the results are better. That is also 63. But they have compared, he has already shown that they are comparable with the biologic, and with the etanercept, it is non-inferior. So this is definitely is a good drug for the pustular psoriasis also. We'll go for the next one. I think next I'll go again to Dr. Sunil Patwardhan. This is the patient, a 35-year-old female patient. She came with a dry, scaly, both involved in the palm soles. Yeah, and the scalp with a lot of scales, crustaceans, and who you see had a comorbidity of hypothyroidism. She is on Thyronorm 150 microgram. She had a history of allergic rhinitis and asthma. So she was suffering for long, so 3 years. So we did a biopsy. Biopsy shows atopic dermatitis. So the question to you, Dr. Sunil, we started the local treatment, but there was hardly any patient was not happy. So can you use immunosuppressant in this patient? Like cyclosporin?
We can try this azathioprine or methotrexate also in atopic dermatitis.
Yes, correct.
Which are cheaper, and we are more used to using these particular molecules. So we can try with those, and if they don't work, then we can go for the drugs like Topatinib. Consider the cost.
So first line you would like to use azathioprine or methotrexate, and if they do not work, they fail, then you can go for the next. But when you are using immunosuppressant drugs, usually we get the following investigation done to rule out underlying latent tuberculosis. Whether you are using cyclosporin, large doses of steroid, or these JAK inhibitors, azathioprine, you are going to use for long, better to get this rule out underlying. So this patient want to test was 18 millimeter positive. Still you would like to use immunosuppressive drug, Dr. Patwardhan?
Yes, sir, we can try. we can use. We have to find whether she has any symptoms, because it may be latent tuberculosis. So if the chest X-ray is normal,
Yeah, there were no symptoms in this patient. Yeah.
she had no symptoms, chest X-ray is normal. Now, 1-2 test can be positive even those who have received BCG vaccination. So I feel that if just on 1-2 test, we cannot say that she has latent tuberculosis.
Yes, correct.
If we can go for IGRA test if you want to confirm, because IGRA is more specific than 1-2 test. But
Yes,
because
correct.
1-2 comes positive even with BCG vaccination, while IGRA won't come positive if even with BCG vaccination. That's what I think.
Renuka, you would like to add something in this?
Sir, as per I have gone to the theories, they have said that if Onto's tests can be positive in any of us, but as X-ray chest is normal and she has no symptoms of infection of tuberculosis, we can start her on isoniazid prophylaxis, as you said that. And it has been mentioned that after giving isoniazid prophylaxis for 1 month, you can initiate the treatment of Tofacitinib.
Yes, correct. That's right. Yeah, so the Monto test strongly positive indicates probably there is a underlying latent tuberculosis. So it's better to give isoniazid as a prophylaxis. And this patient, we started Topacitinib with the Isonex. But the patient had a dyslipidemia. So we changed this patient or switch over to cyclosporine. With the cyclosporine, this patient is doing well. So talking about the TB prophylaxis, see, there are a lot of trial, because the first thing I would like to clear, in fact, Renuka will agree with me, according to WHO, many patients, the IGRA being expensive, Monto test, chest X-ray, and ESR, these 3 investigations are enough to rule out the latent tuberculosis. But the patient can afford, then you can go for IGRA test. But there are trial, and when you start Isonex, usually duration should be 9 months to 1 year. So they have done the clinical trial with the Isonex, and they found Isonex compliance is only 47% to 53%. So just prescribing Isonex is not enough. So now they go for what is called a short therapy. You can combine with the rifampicin, or you can give alone rifampicin, or ionized rifampicin. Short therapy can be given. So the message is you can give prophylaxis and can go for treatment. Now the next patient, I'll ask Dr. Nikam. This patient is 55, complain of hyperpigmented scaly plaque, excoriation all over the body for 5 years. This patient of mine used to come from Lucknow. Patient was on dapazoxatine. There were temporary benefit. Then he had a comorbidity, hypertension. He had gone angioplasty, but there was no history of diabetes. We started with a cyclosporine, but sometimes there was a relapse. Then this patient, we started methotrexate, but he developed dyslipidemia. Sorry, with the azitatine, with the methotrexate, he could not tolerate. Then we started this patient with Topacitinib. And this patient was given even adalimumab. Everything was given. When I started with this patient, of course, after 15 days, say, doctor, why you not started this tablet? These are the words of the patient. But after 1 month, this patient said, sir, I'm getting body ache. So Dr. Nikam, what you would like to do with this patient? Because these are we have to keep an eye on the observation for the side effects. So this patient started getting body ache. So how you want to manage this patient?
Yes, sir. Many of the patients can suddenly show rise in serum creatine kinase. That is, and myalgia can develop. Even within 15 days, patient may show even hepatic dysfunction, and even thrombocytopenia can be seen within 15 days of the Topacitinib.
So as Dr. Nikam has mentioned, we have to keep on observing. But when they see the rheumatologists, they have got experience for last 3 to 4 years, they are using JAK inhibitor Topacitinib. So I discussed with the rheumatologist. I said, probably this patient is developing rhabdomyosis. So I got serum creatine kinase, LDH is done, but it was normal in limit. They said, sir, the JAK inhibitors sometimes they get a flu-like syndrome. Like you start rifampicin, they get a body ache, they get sneezing. Similarly, so he said, sir, you don't stop it, go ahead. Because I was thinking of rhabdomyolysis, because we are new. When we are new, we have to think of whatever the side effects are there. So this was not rhabdomyolysis. Usually they say rhabdomyolysis occur when you use JAK inhibitor with statin. And that is where you have to be very careful. If you are using statin and JAK inhibitor for longer period, the patient may land up into rhabdomyolysis, so you have to be careful. These are the other patients who are atopic. They are responding very well. And you can see this. These are chronic suffering for long, more than 3-4 years. They get very good results. That is our experience. This is another patient. I'll go to Dr. Dhavalchand.
Okay.
This is a 79-year-old female patient, comorbid of hypertension, atopic dermatitis, routine investigation, CBC, LFT, serum lipid profile are normal. What you would like to start? Cyclosporine, methotrexate, which drug you will start among these?
I can start cyclosporine.
No, but patient is hypertension and she's 79 years old.
79
Still
years
you would
old.
like to start cyclosporine? I agree with you, cyclosporine is very effective drug. Yeah.
Very effective drug, but monitoring of hypertension can be done.
Yeah, younger people with the hypertension can be monitored and can be, but usually the elderly patient is difficult, but there is no other option, then he can. I agree with that. Methotrexate we should not use. Even azathioprine, there is a danger of
steroids.
Steroids, again, there will be problem. MMF, the response will be late. Acetretin also, it will take time. And apremilast, Renuka, you would like to add about apremilast and this patient?
Again, apremilast will not act fast. It will take some time to act.
Yes, correct. That's right. Yeah. So what he did in this patient, I think I start on Topacitinib, even she is 79 years, because they said as far as possible not to use above 70. But many of my patient, they are above 70. What you monitor is CBC, because usually there are chances of the patient going into a low hemoglobin or leukocyte count can go down. So Dr. Nikam has already made it that interleukin 4, 5, and 13 has been involved and depends on. Now we'll go for the next patient. This patient, I think I'll ask again. Dr. Dhavalchand, you are there, no?
Yes, sir.
Yeah, this patient had very extensive vitiligo. She has tried, just started systemic steroid, methotrexate, cyclosporine, phototherapy, everything she has tried. And she is the daughter of one of my colleagues where I work in the hospital. She came to my clinic. She said, what is the latest drug? She stays at Pune, but she comes for the treatment. I said, we'll try Tofacitinib. But after 2 months of the treatment, there was no improvement at all. So Dr. Dhavalchand, how we can go ahead?
Has she tried with
any improvement after 2 months?
Okay. Has she been put on already a narrowband UV therapy?
No, without that.
So narrowband UV therapy remains one option.
Yes, correct. No, she has taken narrowband as alone, but not with the combination with Tofacitinib. Yeah.
Okay. So we can add on therapy with narrowband UV along with Tofacitinib if you want to continue.
Yes, correct. I agree with you, because they say usually the 2 months are not enough. The vitiligo repigmentation takes about 5 months, that is about 20 weeks. So you have to wait for 4 to 5 months to see the result. But as Dr. Dhavalchand say, because I'm conducting all of the country, many people have suggested narrowband with Topacitinib. The results are very good. Then I tried in one of the patients after listening to them, and I agree with Dr. Dhavalchand. If you have a combination, results are faster and better. So we'll go for the, Yeah, we'll go for the next question. Next question is to Dr. Mahajan. Dr.
Yes, sir.
Mahajan, can you combine apremilast and tofacitinib together?
Sir,
So they say azathioprine, cyclosporine, steroid, as far as possible, should not be combined with. Dr. Nikam has made it very clear with tofacitinib. So can you combine with apremilast?
yes, sir. Actually, sir, there are no drug interactions of apremilast and tofacitinib if used together. Theoretically, there are no
I
contraindications.
agree with you. This is the large study where they say the best combination will be tofacitinib and apremilast can be combined, and they are is a very good combination. And that's why when I was talking with Dr. Nikam, they said the patient comes with the atopic. Once they are on tofacitinib, it works very well. But if you stop it, they are likely to get recurrence. I think where the maintenance therapy can be apremilast. I think panelists, you would like to add on that, because we can slowly taper the tofacitinib and switch over to apremilast for a long term. Even psoriasis, I'm doing that. So I would like to have opinion of panelists. Anybody want to add about the maintenance? Because JAK inhibitor, you cannot continue for long. Of course, there are studies you can continue for 8 or 9 years. These are the studies. But I would like to have opinion of the panelists. Anybody? Yeah.
But in the previous case of the patient who had got vitiligo, we can increase the dose to say 10 mg 2 times a day.
Yes.
But we should note that only a single therapy with tofacitinib is not very effective, but I think it should be combined with low dose narrowband UVB or sunlight therapy.
That's why I mentioned
or sunlight.
the combination tofacitinib with the narrowband is the best combination. That is the experience across our country, and that's what now I'm doing that. Yeah. So we'll go for the next patient, that is Alopecia areata. Dr. Nikam has showed many patients with Alopecia areata. This is one of my patients. She had come with the Totalis. We started with the methotrexate. This patient, she was doing very well, but after some time she showed the all good, very good improvement. But after some time she stopped methotrexate, and again she came with the loss of hair. When she again came with the loss of hair, we started this patient on tofacitinib twice in a daily. Yeah. But she was doing very well, but now she wants to get married. So Renuka, what is your advice about to continue tofacitinib, discontinue, or what we should be doing?
As far as her marriage is concerned, she can continue the tofacitinib, but if she's planning for pregnancy and all, then you should counsel both husband and wife regarding its as if the patient becomes pregnant, we do not know whether pregnancy as it is category C, so we cannot use tofacitinib in that pregnant women. So you have to advise counseling of the patient. It's both the husband and wife is important. Ask them to use barrier contraception, and whenever they want to go for pregnancy, advise them to stop. And I would say for at least 3 cycles of her this, she can go ahead with the pregnancy.
Yeah, I agree with you, because there is a washout period. They said washout period is 1 week. So tofacitinib can be discontinued for 1 to 3 weeks. I usually tell them to 3 weeks, and then can go ahead for the conception, but better to avoid, because there are no trial, no safety, so better to avoid. Yeah. So which is then safer drugs in pregnancy?
Cyclosporine is better.
Yeah.
Cyclosporine and steroids.
Yes, correct. I entirely agree. Cyclosporine is the drug. We can be used in pregnancy. Throughout the pregnancy, there is no problem. Yeah. So this is the another patient, Alopecia totalis. See, after 2 weeks of tofacitinib, but the dose I had given was 10 milligram BID. It was not 5 milligram BID. So then there is another patient. He came with a loss of eyebrow. We started tofacitinib 5 milligram BID. He got the eyebrow, but his question was, sir, what about my eyelashes? He could not get his eyelashes. So I would like to ask panelists, Dr. Dhaval Shang, what is your suggestion or answer for that?
Eyelashes.
Because eyebrow, he got it. Eyebrow hair, he got it. Yeah.
I think eyelashes getting back is very difficult for him. Only with drug Tofacitinib.
Yeah. So
you can add bimetoprost, no?
Bimetoprost works very well. Bimetoprost.
Yeah,
Bimetoprost.
that we can add. But then they said to get eyelashes, you have to give Tofacitinib at least minimum 4 months. After 4 months, you'll start getting it. Don't be in a hurry. That's why literature says. This is another patient of mine. I'll ask Renuka only because this patient came with, after starting Tofacitinib, he came with, sir, I'm losing hair. And this is the picture. What do you think, Renuka? Is it because of Tofacitinib or Dr. Mahajan?
Sir, I don't think.
Yeah, sir. Even I don't think it is due to.
It's not due to Tofacitinib.
Yeah, because this looks like a male pattern.
Male pattern.
Male pattern.
Yeah, but he came with this bundle of hair, you know. Usually the ladies come with this. They bring
So
in
it
this.
can be due to telogen effluvium
post-COVID.
Hemoglobin drop.
I think very nice. Any patients of came and then from the history
COVID inspection.
had a COVID about 2 months. Absolutely right. Very nice thinking, because now anybody comes with a hair loss, you have to ask history of COVID in the epidemic. Okay, so is a telogen epidemic? Absolutely right. I'm very happy. So this is another patient of lichen planus. Is an old lady. We have started. She has been used steroid. She has been taken steroid, methotrexate, cyclosporine, azothioprine. We just mentioned she has taken everything. But when she came, she had all this hypertrophic. So we did a biopsy. Biopsy shows the pseudocarcinomatous hyperplasia. But I started this patient on 5 milligram BID. She was above 70, but she improved. I was surprised, you know, hypertrophic lesion disappeared within 6 weeks. But after some time, she came with the swelling of the leg and was tender, but lichen planus have settled down. So, Dr. Nikam, what do you think?
Possibly of secondary cutaneous infection, cellulitis or something
cellulitis.
Like that. Yeah, I entirely agree. This is cellulitis, because when you put patient on Tofacitinib old, they're likely they get a bacterial infection, and one of them is cellulitis. I entirely agree. So now we should continue Tofacitinib or we can stop it.
You can treat with antibiotics and continue Topacitinib.
So we started with the linezolidine and see everything settled down. According to literature, during infection, better to stop it and then you can restart it, because that's better to stop during the infection. Yeah, this is the slide. Of course, and today, one of the doctor who had bullous pemphigoid, I started on Tofacitinib. After 3rd day, he phoned me, sir, this is a wonderful drug. Now most of the lesions are settled down. But after 2 weeks, that is today, he has sent me a picture. He's a doctor. He said, sir, looks like I'm getting herpes zoster. So how commonly see herpes zoster with Tofacitinib?
I've seen only once.
Yeah, and usually it's a mild, not what we used to see in HIV. Correct, no?
Yes, sir.
Yes.
I discussed with the rheumatologists because they are more experienced than us. They said, sir, hardly you can start acyclovir and you can continue. As Dr. Nikam said, in infection you also can continue. The year also, then herpes zoster, you start with acyclovir and you can continue, but it should be low doses. That's why they were suggested. This is another patient of lichen planus. After 2 weeks, see, these are the hypertrophic lesions. Everything disappeared. This is a patient of mine with the HIV. we treated, but when you are treating with the HIV-C, their CD4 count has to be more than 250. Otherwise, there will be more suppression. Now, how to monitor this patient? I think I would like to ask this question to Dr. Renuka. How do you monitor the patient once start on Topacitinib?
After a month, again, we have to do complete blood count, renal function test, liver function test, and fasting lipid profile. And this has to be done every 3 monthly, and even ask for the patient for the symptoms like weight loss, fever, any cough, and any lymph node swellings anywhere. Then it is said that to monitor even for tuberculosis, you have to yearly you have to do investigations. But again, I would like to go as per the clinical presentation of the patient. Monitoring his lipid profile is very important. One of my 2-3 patients even got fever after starting Tofacitinib for after a month. Actually, a patient himself landed to a physician. He did n number of investigations, but all were normal. So I asked the patient to continue the same drug 5 mg BD, and with that patient is doing well. So sometimes symptoms like fever, body ache can occur in a patient of Tofacitinib after 4 weeks.
Yeah, that flu-like syndrome. That's a very good experience.
Yes.
Yeah, thank you, Renuka, for that. But usually CBC, serum creatine, SGOT, AGPT are very important. First months, of course, after 3 and 6 months, in addition, you can get cholesterol level. That is very important. And as Renuka says, that whenever the patient comes, keep in mind about tuberculosis, because you are using immunosuppressive drugs, either is a cyclosporine, steroids. I'm telling from my experience, any immunosuppressive drug you're using, whenever the patient comes, look for TB. That's very common. Yeah. So we know all these are the side effects. Dr. Nikam has mentioned thrombocytopenia, but that is occur usually when the doses are high. Usually 5 mg BID or 10 mg BID is not. Even malignancy, they say doses are 30 mg or 40 mg, then there are chances of malignancy. Other than malignancy in a patient without Topacitinib and with Topacitinib, they are comparable. Yeah.
The chances of infection are very high, sir. The chances of
Pardon?
infection. The chances of infections are high. Two of my patients of Alabashi Areata got scalp abscesses, and one has to be drained from the surgeon also.
Yeah. So how long that Topacitinib was given to that patient?
The Topacitinib 5 mg BID was given only for I think 1 month was over, and she got abscesses, multiple abscesses, 3-4 abscesses.
What patient was elderly or young?
No, very young patient, almost of 17-18-year-old female patient.
Yeah, that is a very good experience. But usually 5 mg BD in the young people, they tolerate. Elderly patient, I showed that lady, with the lichen planus, she landed with cellulitis. But as Dr. Dhaval Singh says, we have to keep it in mind, and we have to be very observant about the side effects. Yeah.
And there was a very much derangement of liver profile in another patient. Too much SGPT higher, to the tune of 300 SGPT, SGOT rise.
Oh, but that is only one patient. See,
only one patient.
I'm using this molecule for last 1 year and 3 months, and there are SGOT, SGPT I've seen going up to 70, 80. But usually, if we give that UD-Lev or Levomine, this one is the Levominase or the liver tonic, it comes down. So in mild cases, we can continue. Unless it is severe, then only we should not continue. We should stop it. Yeah, in the DVT, any patient is a DVT, you have to be careful. Yeah. So there's another patient of atopic of mine came with a diverticulitis. So can you use Topacitinib, Dr. Nikam?
Sir, there are few reports of it's common that dyspepsia and other symptoms are common with the Topacitinib, but there are few reports of gastrointestinal perforation. So
Yes, correct. Yeah.
one should avoid initially, at least the diverticulitis, inflammation all get settles down, and later on can be tried.
Yeah. So thank you, Dr. Nikam, for this information. Because in diverticulitis, it's better to avoid the drugs because the chances of perforation is high. They said any patient is on, he has taken the steroid, high doses of steroid long term. Tofacitinib, you have to be very careful because there are chances of diverticulitis. You have to, sorry, perforation. So you have to keep that thing in mind. Yeah, these are the contraindication. We know that. Then we'll go for, yeah, another question. Patient of mine with atopic with the tinea, can you use tofacitinib? I think I'll ask this to Dr. Mahajan.
Yes, sir. So actually, tofacitinib and you cannot use it with ketoconazole and hydroconazole because they are both metabolized in the liver. So I think you can use topical agents if needed, but it is better to not use ketoconazole and hydroconazole drugs.
I agree with you because ketoconazole, itraconazole, or tofacitinib, they are metabolized by CYP3A4. So we cannot use that. But can you use fluconazole or no?
So it, I think a low dose may be tried, 150 mg a week or something like that.
Even fluconazole also.
But it is better to avoid. But yeah.
But why we should avoid? Why we should avoid? Because this is my very favorite molecule. This is a research molecule of Dr. Saple.
Yes.
See, that's why I say the metabolism of tofacitinib, itraconazole, ketoconazole is through CYP3A4. Because many people say itraconazole, fluconazole, azole, their metabolism is the same, but no. Fluconazole has been excreted through urine or through kidney renal, hardly any metabolism in the liver, and that metabolism is 2C9, not with CYP3A4. So fluconazole can be used. There is hardly any drug-drug interaction with the fluconazole, so can be used. Yeah. So these are the drug interaction we have mentioned it. I'm not going detail. I think we'll go now for question. Can we go, or panelists wants to suggest anything, or can we go for the questions from the audience?
It's better to go with the audience questions.
Yeah, we'll go with the question, and I think I'll stop it here. Yeah. I think Mrunali, there are questions, no?
Sir, right now we have got no questions from the audience.
Pardon? Okay, then we I think we'll take this another 1 or 2 cases. Okay. So before closing, I would like to have this advice of all panelists and speaker. So first, I would like to ask Dr. Padwardhan, you being a senior person, what is your message as far as tofacitinib is concerned?
I feel that tofacitinib is the first generation JAK inhibitor, so it has sort of non-specific actions. So maybe it's no doubt a good introduction to the armamentarium, but we have to wait for the newer molecules in this this type of molecules, like which are more specific. Just like we had in asthma management, we had beta blockers initially, but later on we had more specific beta blockers. Not asthma, this cardiac patients. Like
no, I'm asking the message for the future of tofacitinib.
Yeah, future is definitely there. We have to keep on using it for newer and newer indications, and especially those cases where the other usual drugs have failed. At the same time, we have to be careful because it's a new molecule. Whatever we are using is off-label, so we have to be careful considering the patient's concerns and patients' queries, because they always want to they always search Google. So we have to be careful regarding regarding the use. We cannot use it just like that. We have to monitor the patients properly. We have to do the before starting, after starting. Proper monitoring is most important.
Thank you, Dr. Patwardhan, for your message. I entirely agree with you that even it is a fascinating drugs, it's a rescue drugs, but but you have to use for long, try to learn, and then you prescribe. You should not be in a hurry, but we have to start using. There is a good message. Now I'll go to Dr. Dhaval Shang. What is your message?
Again, any new drug comes, it is a good to try initially until and it is proved that it works in that condition. Especially, there are good reports about working it in Alopecia areata. So the many people have tried in Alopecia areata, and it has given very good results because we had a very less things about Alopecia areata in armamentarium, especially for Alopecia totalis.
But do you think this drug is going to change the dermatological therapy?
It is not entirely going to change the dermatological therapy. It will be another good weapon in our armamentarium, especially some kind of disorders like alopecia areata, like vitiligo. We are frustrated in many cases about vitiligo. There it can be a drug which, if it works, it will be a very good boon for the patients.
Thank you, Dr. Dhaval Shang, for giving the message. This is like rescue drugs. Whenever there are recalcitrant, whether there's psoriasis, atopic dermatitis, alopecia areata, or inflammatory dermatosis, where this drug is there to our rescue. Thank you. Thank you very much for that. I'll go to Dr. Nikam. What is your message?
So two things. First of all, Tofacitinib being a JAK inhibitor, now it's being used widely for many dermatological diseases. But at present, surely we can use it is in alopecia areata. Future is there definitely, but probably we are yet to know many of the things about the Tofacitinib, particularly how effectively or how safely we can use it in combination therapy, like with methotrexate or with cyclosporine, because in ulcerative colitis they are using with cyclosporine. In rheumatoid arthritis, they are using with methotrexate. They are using with along with steroids. In atopic dermatitis, there is a report of combination of dupilumab and Tofacitinib. So these kind of combination therapy will definitely work and helpful will be in recalcitrant cases. So that is the future of Tofacitinib. Apremilast is another small molecule which was very being used by dermatologists, but it is an unpredictable molecule. In that way, Tofacitinib is definitely predictable at present in alopecia areata. In other cases like psoriasis, lichen planus, in DLE, atopic dermatitis, it is working at least in 70% of the cases. In 30% of the cases, we are getting failure or not immediate action.
I think Sir has left.
I think he wrongly left. He'll join. His connection was
weak. Yeah.
Yeah.
Unstable connection.
I think Nikam Sir can take over.
We will join it. We were just discussing about this. I think everybody is happy with the alopecia areata.
Yes, sir. True.
Because that is giving, like, you can confidently say that in a 3 months time you will get a good result in any of the patient, unless it is very vastly alopecia universalis. But most of the patient they do respond in 3 months time. That too, eyebrow shows quick improvement.
So I think there are two issues with this drug. One would be the cost.
Oh, sorry. Yeah.
No, sir, please go ahead.
Yeah. You please continue.
So, sir, I think there are two main issues with the drug. One is the cost, and second is the recurrence. The patients don't mind spending so much, but they want 100% it should remain. The results which they get should remain for a long time. That unfortunately we cannot guarantee as of now. And I think till then, this drug should be used as a second line or third line therapy. I feel.
As a while, for every drug, it is like that only.
Yes, sir.
The recurrences are known to for that diseases, not because of that drug. You have to maintain it. That you need to counsel. That's a different part. But at present, like in alopecia areata, if it's multiple patchy alopecia areata, we are choosing first drug as an topacitinib. So combination therapy.
My experience. I would like to share my experience in a case of psoriasis. This patient was on adalimumab for a long time, about not very long, about 6 to 8 months. He was very happy, but then he started complaining about the cost. So that time tofacitinib had come. So I said, let's shift to tofacitinib. But I could not get that good result as compared to adalimumab. So after 2 months or 3 months, I shifted him back to adalimumab, and now he is doing well. So what is your experience? Have you compared?
Particularly those who have used biologicals, they will respond to very higher dosage of topacitinib.
Right.
And we are using 5 milligram BD. We are not yet using 15 milligram or 20 milligram. But only in one case I have used 15 milligram. Yeah. Otherwise not, because it increases the cost a lot. Yes, sir.
What's the logic? Why does this happen? I mean, like those who have used biologics, why don't they respond to tofacitinib? And what's the logic? And what's the?
I think there must be some changes about the interleukins and cytokines.
Okay. Possible.
Okay. And topacitinib, particularly in psoriasis, immediate actions are seen, no doubt, but it is unpredictable. Immediate actions.
Right. That's what my experience was.
Same like Apr Hrs.
Yeah, exactly. And one more thing is that they should come out. I mean, this is a suggestion to the hetero pharma. They should come out with a tofacitinib ointment also. They should try it. We can try in some cases. Tofacitinib ointment.
Got it.
The topacitinib ointment is very much helpful, in particular in vitiligo.
Right.
Application and phototherapy works very well than the oral topacitinib.
Topacitinib. Yeah, it will be safer also. It will be safer also to use, right?
Yeah.
Only thing, if it starts working magically, then it will be an OTC drug. Particularly for alopecia.
Right.
Sir, Doctor, I just spoke to Dr. Saple. Unfortunately, he got disconnected and he will not be able to connect. So let us have a closing remarks. We really thank you everybody to be part of this webinar. I'll start from Dr. Saple, sir, for excellent moderating this session. As always, one more academic feast we have experienced in this evening. And definitely Dr. Balkrishnan Nikam, sir, for delivering a very lucid talk in the given time and covering all the points very well. We thank Dr. Sunil Patwardhan, sir, Dr. Ganesh Dhavalchand, sir, Dr. Renuka Astekar, ma'am, and Aditya Mahajan, sir, for being an esteemed panelist for this event and sharing their wonderful experiences. Like every webinar is important, this webinar has also given us various insights in terms of clinical usage of tofacitinib. And we have taken up your comment, Dr. Sunil, sir. We are already working on developing the topical formulations for tofacitinib, and soon we'll be starting a CT as well on this. So once again, we'll close this session and thanking everybody and the audience for being the part of the scientific feast again. We'll be sharing this to all the panelists so that it can be further given to your colleagues and students. Thank you once again.
Thank you.
Thank you very much.
We can be for a moment on this once it stops.